Good morning. I'd like to thank SAGES for the invitation to present. Today, I will be discussing our study entitled Appropriate Patient Selection Facilitates Safe Discharge from the PACU After Laparoscopic Ventral Hernia Repair, an analysis of the AHSQC database. We have no disclosures for this presentation. Despite being one of the most commonly performed general surgery operations, ventral hernia repair lacks standardization with respect to all phases of perioperative care, including the choice of surgical approach. The laparoscopic approach to ventral hernia repair was first introduced in 1993, and several studies since that time have shown that laparoscopic ventral hernia repair is both safe and effective. Currently, over $3 billion is spent in the United States for the repair of over 350,000 ventral hernias annually. Laparoscopic ventral hernia repair has been shown to have a decreased rate of postoperative wound events and hospital length of stay compared to open ventral hernia repair. In recognizing the evolution in our healthcare landscape from quantity of care to value-based quality of care, and the contribution that postoperative wound events and hospital length of stay makes to the overall cost of ventral hernia repair, it is important to identify the specific subset of patients that may benefit most from a laparoscopic approach to ventral hernia repair. Which leads us to the purpose of our study, which is to determine if there are any patient and hernia-specific factors that contribute to hospital admission following laparoscopic ventral hernia repair with mesh, and further, to determine if there are any differences in 30-day wound events, additional 30-day morbidity and mortality, as well as pain and quality of life scores between patients who are discharged from the PACU and patients who require hospital admission following laparoscopic ventral hernia repair with mesh. In order to do this, we use the America's Hernia Society Quality Collaborative, also known as the AHSQC database. The AHSQC database was established in 2013 in an effort to improve the value of hernia care. The AHSQC database includes surgeon-inputted data and is advantageous over other large databases as it includes hernia-specific variables such as mesh location and the size of mesh used for ventral hernia repair. The AHSQC database includes data from academic, community, and academic affiliated institutions, and at the time of our study, it included data from 119 surgeons. All patients who underwent elective laparoscopic ventral hernia repair with mesh placement from October 2015 through April 2019 with a CDC wound class 1 who had hospital length of stay and 30-day follow-up data available were eligible for study inclusion. While the AHSQC database was established in 2013, the indications for ventral hernia repair were expanded from symptomatic to symptomatic, enlarging, and pain in October 2015. Because we felt that the indication for ventral hernia repair may be associated with either hospital length of stay or 30-day morbidity and mortality outcomes, we elected to remove all cases prior to October 2015. All patients who underwent emergency ventral hernia repair, patients who underwent laparoscopic ventral hernia repair without mesh placement, patients who underwent open or robotic-assisted ventral hernia repair, patients who underwent concomitant peristomal hernia repair at the time of ventral hernia repair, or who had any other indication for a CDC wound class other than 1, patients without information regarding length of hospital stay or without 30-day follow-up data available, and those patients with ascites or known chronic liver disease at the time of ventral hernia repair were excluded from our analysis. In order to perform our analysis, patients were divided into 2 groups, including patients who had a length of stay of 0 days and patients who had a length of stay of at least 1 day. Within the AHSQC database, hospital length of stay is captured in days and not hours. Therefore, patients who are discharged from the PACU have a length of stay of 0 days, while patients who require hospital admission have a length of stay of greater than or equal to 1 day. A total of 1,609 patients met inclusion criteria. 901 of these patients, or 56% of the cohort, were discharged from the PACU, while 708 patients, or 44% of the cohort, required hospital admission following laparoscopic ventral hernia repair with mesh. We first investigated patient and hernia-specific factors associated with hospital admission following laparoscopic ventral hernia repair with mesh. Patients who were discharged from the PACU varied significantly from patients who were admitted to the hospital on univariable analysis on almost every patient demographic, operative, and hernia factor. Following multivariable logistic regression analysis, older patients, patients who underwent laparoscopic ventral hernia repair with a larger mesh size, patients with a higher ASA class, patients with a longer operative time, patients who underwent another procedure at the time of laparoscopic ventral hernia repair, patients who underwent incisional ventral hernia repair, and patients who underwent mesh fixation, specifically with a combination of sutures and tacks versus tacks only, were more likely to require admission to the hospital. In terms of 30-day wound events, patients who were admitted to the hospital were more likely to experience a surgical site occurrence than patients who were discharged from the PACU. Interestingly, the most common type of surgical site occurrence in both groups were non-infected hematomas and seromas. There was no statistically significant difference between the two groups in terms of the incidence of surgical site infection or surgical site occurrence requiring procedural intervention. In terms of additional 30-day morbidity and mortality outcomes, patients who required admission to the hospital following laparoscopic ventral hernia repair with mesh were more likely to be readmitted to the hospital or to undergo a reoperation compared to patients who were discharged from the PACU. Finally, with respect to pain and hernia-related quality of life scores, patients who were discharged from the PACU had a greater improvement in their pain scores at 30 days postoperatively. There was no statistically significant difference between the two groups with respect to changes in their hernia-related quality of life scores. In conclusion, appropriate patient selection and surgical approach are important tenets to a value-based healthcare system. Our study found that younger patients undergoing first-time ventral hernia repair with relatively small defects may be safely discharged from the PACU following laparoscopic ventral hernia repair with mesh. Further studies are needed to determine if these criteria lead to further improvement in postoperative pain and hernia-related quality of life scores, and if they lead to an overall decrease in hernia-related healthcare costs over the long term. Again, I would like to thank SAGES for the invitation to present today. I hope that everyone listening remotely is safe and healthy.